So I just want to thank everyone for joining us this evening. I'm Katie Osborne. I'm the chairperson for the membership committee for GSASEP. Thank you so much for joining us on our quarterly webinar, being the end of September now. Gosh, these months are flying, flying by, even though it's still 90 degrees here in Tennessee. But I just want to briefly introduce Commander DeForest. So she'll be giving her lecture on mastering trauma treatments and focusing on penetrating injury management. So she is our lovely president-elect for GSASEP. She is an emergency medicine physician working at UPenn. Did you move over to Chicago or you're on your way?
We we fall under Chicago, but we are still working at Penn, so
All
that's a
right.
nice transition. Yes.
So she's at UPenn Trauma Center through the MILSIV partnership. She has 16 years of experience in the Navy and will talk about assessment and management of trauma. So if you want to go ahead, Dr. DeForest, and go on with your awesome lecture.
Thank you very much. Thank you for the invitation to speak today and certainly to share. I am I'm going to adjust my slides just so that I'm sharing as content only so that you will see full slides. And let's see. And that should, let's go that direction. That should have us on the first slide there. And because I'm functioning with the full slide screen, I don't have visibility on chat. And so Michelle, our outstanding executive assistant, is going to be able to help us in doing that. And I will also pause periodically. So if you're putting anything in chat and questions, please draw our attention back to it since I'm not able to monitor that simultaneously. So today we're going to be discussing trauma, and we're going to review a general framework of trauma as well as adding in some aspects for when we as military physicians are treating patients in limited settings. I am Commander DeForest. I am an emergency medicine physician in the Navy. This is the start of my 16th year, and I've had a variety of experiences. I am more than open for questions. I will share my contact information. If you yourself are deciding where you might be, I am always happy to talk about that because I've had some outstanding experiences. But right now I am at the Navy Medicine Readiness Training Command. I am in Great Lakes, and we are a unique detachment at University of Pennsylvania, and I'll go into that in a little bit more in a few moments. Standard disclosure, these are the thoughts and content of my own. I do have a TLS framework that will have our discussion here, but I have no personal or financial disclosures, and these are the thoughts of my own and not that of the military. So a little welcome from our team here, and I may escape out of screen sharing for just a second because I would love to have a show of hands for those that are currently a medical student, maybe considering emergency medicine. And if you are in a time and space that you're able to show your hand, I would just love to understand our audience a little bit more. Thank you. And if you yourself are currently a resident in emergency medicine, or perhaps in a one of those gap years where we in our military call OMO years and are exploring between internship or residency, I'll cut you in this group as well. Do we have any residents in the audience? Thank you. Great to have you with us. And then, do we have any fellows? Anybody who is in a training program of some form? How about our attending physicians out there, staff, maybe first tour or have been around a few duty stations like myself? Great. And we have some within our chapter who are government service or who are tied to our chapter through an affiliation with the DoD or even in our VA counterparts. If you are able to identify yourselves as well, great. If there is anybody that I left out, um, please feel free to add yourself into the chat. It helps just in knowing our audience as I gear some of our discussion today. All right. And a friendly reminder at this point, go ahead and mute yourself as we move into our presentation. I'm going to share our slides again. You should see that, and I will put ourselves in presentation mode so that there's a little bit better visibility. So welcome to everyone. This discussion today will really look at a framework for trauma, and I think that it is beneficial and hope that it's beneficial to every one of you because it will have the framework for reviewing systematic assessment as well as some interjection in different deployed settings. And we learn from one another. It's we are in a journey in medicine that is always lifelong learning, and we especially are stretched to do that in emergency medicine and in the military where we work in some pretty unique positions. So I right now that am working with a team, which is an ERSS. We are a small team positioned at the University of Pennsylvania Level 1 Trauma Center, which is Penn Presbyterian. We benefit from the experience of one prior team that was installed. And there is also, for the Navy, a military civilian partnership in Cook County that has 3 teams in strength. As we move into the next 2 years, Penn will also be growing to 3 teams in strength. And what that means is that there's one emergency medicine physician with each of our teams. Right now, I am solo, fully welcomed with open arms by Penn, but the sole emergency medicine physician in our team. We have a general surgeon, a anesthesiologist. Some teams have a CRNA, and I saw somebody in anesthesia training. So some have CRNAs, some have anesthesia, and then we also have some outstanding nurses. We have an emergency medicine nurse, an ICU nurse, we have a surge tech, and that is our core team. We are supported by a trauma surgeon as well as a perioperative nurse and a healthcare administrator that helps. Not seen in this picture, but definitely represented by those that are flanking us on either side, is a SMT that has joined us just over this last summer, and we have been so excited and eager to have him. One of the benefits that we have working in the Penn system is that we also are able to work alongside Penstar, which is does helicopter or uh, ambulance transport for patients. And occasionally we'll get people from the scene. More so, it's inner hospital once they've been stabilized, or when we receive patients that have been initially evaluated at a non-trauma center, and we gain those. So the initiative is really to help in looking at how we establish strong trauma skills and together as a team have worked together to stabilize and treat patients and can be more effective when we deploy. Prior to this experience, my deploying teams were primarily simulation supported. And so we trained through a simulation exercise, variety of patients that came in to be able to help us in learning one another as well as some gear familiarization. And that is definitely heavily used throughout the military in preparing for deployed environments. Slight disclosure here, I have a certification from the Navy Postgraduate School in simulation. I hands down love simulation. I think it does an outstanding job in giving us a chance to be able to practice and sustain skills for low frequency procedures. Also, when it helps to engineer an environment that can be high stress and with specific critical patients to be able to work through that. We in emergency medicine pride ourselves in taking care of anything that comes in the door. But the flip side of that coin is that it may be a little bit of time between certain cases, and simulation does a great job in filling that. in military, simulation is the same thing. When we look at preparing to be deployed, to function in caring for patients in full battle rattle, it really is something that helps us in doing that. But I get to work alongside these great colleagues here, and I share those lessons with you in the presentation that follows. So in Philadelphia, we are somewhat unique. It was definitely selected in that there is support by veterans who have gone before us and are invested in the trauma program, but also in that there's penetrating trauma within our city. And when you look at this heat map, you see that there is definitely a high concentration within the Northeast as well as the West, Philadelphia, and we are positioned just over in the West. And so we're pretty close to some penetrating trauma. Furthermore, we benefit out of a Philadelphia drop off system. And so these numbers are through July, where there was high frequency of shooting incidences, and that's what's tracked with victims. And we are just over into what on this map, just to the left side there. And so police, if they deem somebody of high concern, either peri-arrest or immediately post-arrest and they're right around the corner, they scoop and run. So we have patients that will come in, no care, no EMS assessment, and our outstanding techs and nurses help us as we are preparing in the trauma bay, and they support from police in grabbing that patient, dropping them onto a gurney, and wheeling them in the doors. And so we have some pretty fresh trauma, and it with minimal or no notice at all. Our community also knows that. And so we will receive patients that are pulled out of a car and dropped off for care. And that is a real advantage to our military team working because it is the closest to what we would get for being deployed downrange. So today, as we move through the subsequent slides in our time together, I would like to instill within you confidence in your algorithmic approach for trauma assessment. With that, we will look at becoming more confident in how to adapt to being deployed. And that will help us when we integrate with teams, whether it be those that have been trained through simulation or those that we maybe have worked alongside one another in an MTF for medical patients, but not trauma care. And so you yourself will gain an exposure that you can share with your colleagues as you function, because we in emergency medicine function as teams. And we are the ones who embrace that unknown, that red line. And sometimes it takes our encouragement and confidence for the rest of the team to be as comfortable in dealing with that gray area. All right, so we're going to set the stage. So, a variety of pictures here. The case that I give you today is a case out of my trauma experience in the comfort of University of Pennsylvania. But this case could be cared for in a variety of settings. What you see on your slide left is the aid station that I first was introduced to within a year of graduating from internship as a flight surgeon. I was in Iraq and it was desert environment, and certainly you can see that it was positioned to be able to easily ramp in patients. We were on a base at that point that had a variety of staffing and medical assets in different areas that I really gained an experience from, and I'm grateful for the colleagues that I worked with. You see on the slide right a tent. And when we look at future conflict, I frame this that we may or may not be in a tent setup that has a variety of square footage, if you will, because we're really challenged to look at smaller footprints, less gear, and functioning as a smaller team. And when you look at the equipment that's staged outside of this tent, you're seeing large AMOL cans that has a variety of equipment that is used like Rubik's Cubes to be able to stack and ship all of our equipment. And when I now prepare as part of an ERSS, we are much smaller footprint. every piece of gear matters, and how it fits into each can makes a difference. And furthermore, that weight makes a difference. In the middle, we see the hospital ship and a little bit of tidbit for those trivia. You will see that, and if you pay attention to pictures between the Comfort and the Mercy, they can be uniquely identified based off of where that hospital cross is. But this is the Mercy, and I will share a picture of our team off of that as well. But this helps you, and what I challenge you to do is kind of shift your framework out of the comfort of the day to day in a hospital setting into what could be either planned, where you've had a chance to orient with teams, or maybe you've picked up and dropped somewhere that is pretty remote and definitely is far from your standard controlled hospital environment. Definitely challenged by what you have on gear, definitely challenged by the weight of everything. And in the front of this picture, which is one of the reasons why I have this picture, is a reefer and looking at cooling blood. And so the logistics, and we'll get into blood in the final third of our slides today, but it really goes into how do you temperature regulate and how do you manage that while you're deployed. We are also challenged to work not just in a true deployed setting, but also in some challenging military locations. And so this is a picture of the hospital in Guantanamo Bay, and Navy has a hospital positioned there purely to routine travel there, and routine with air quotes, takes more than one flight, a ferry ride, and further transportation on land. And so you can think about the challenges of evacuating a patient when there isn't planned ground or ship movement and how you're going to evacuate patients. And that's one of the challenges that we deal with some of our established military bases, and something that we as emergency medicine physicians may have with a regular set of orders. And so that evacuation plan becomes paramount because it helps in understanding how, as a small team, do we need to function for 12, 24, potentially longer hours to be able to manage a critical patient. All right, so know your team. Know who you work with, definitely train, and oftentimes we may deploy and work with international partners. And that's one of the benefits if you ever have an opportunity to do a humanitarian mission. And that's why I include the Mercy slides with us here, because we learn so much from our international colleagues. But also, if you think back to one of those, that first slide, when I showed pictures of aid stations, also when we look at evacuating patients, it can be determined by their nationality and the resources in the area. And that may be that we are then handing a patient off to a NATO facility and coordinating those plans. So in the future, in the Stevens photo that looks at in the military, especially in the Navy, how we look at adjusting ourselves into the smaller teams, as I pictured originally, and how we position ourselves onto future hospital or non-medical assets so that we can be functional and we can best be positioned to reduce the amount of time it takes for patients to be evacuated and cared for. So a little bit of the case, that was the background that was setting stage. But when we look at the case, and this case is going to be in the setting of our trauma bay, which you see highlighted on the left slide there, but it equally could be anywhere. And as you see, simulation options, think of stretching your mind to where I show you kind of top right. Maybe you're working out of a backpack. And maybe you are working in an established military hospital, but without trauma capability and without surgical subspecialties. And that's the picture of my Guantanamo Bay room on the bottom right. So this is a 16-year-old male who was brought in by police. As I said, police drop off. We get those with no warning. concern for gunshot wound. So they had heard gunshot fire. They had come upon this patient that was on the ground. They pulled them in the back of their car and they brought them in. And it was about 5 minutes for them to arrive. It, we work in a systematic approach. And so as you see here, and I'll top right of slides will kind of remind us a little bit of our ETLS. We function best when we have a system approach. It reduces our chance of missing critical data and also missing critical action points. Or unfortunately, if we are too haphazard in our assessment, it takes us too long to address some of the initial. So if somebody could take themselves off mute and help me in filling out our primary survey, just what each of these letters stand for.
Airway.
Airway, great. All right, so you want to hear about our airway for our patient. His airway is patent.
Breathing.
Breathing. All right. So there are asymmetric breath sounds for this patient. He has good air movement on the right. He is markedly diminished on the left. And we'll move on to C.
Circulation.
Circulation. So in assessing our circulation, we look at central and peripheral pulses. It goes into the context if there's extremity injury, if there is a tourniquet, if there is an amputation. But with our circulation, we're purely looking at our quality of pulse. And this patient has present radial pulse bilateral. That's important as we go into some of our adjuncts as I go into that, and so I'll draw your attention back to that. All right. Another aspect that goes into our circulation is that at this point we've got a blood pressure. It's 130/80. This is a manual blood pressure. We got that up front, and that correlates with the ability to palpate a peripheral pulse. If I said that it was 70/palp, and I unfortunately can't see the raise of hands, but I'm going to still ask for some audience participation. Should I have radial pulse at 70/palp or 70/50? Who thinks that, a raise of hands, who thinks I should have peripheral? All
No,
right.
radial pulse typically goes away at 80 systolic.
Excellent. Thank you very much. So, so we looked at that and putting into context. And so that helps us in understanding a bit of their circulating volume. And so if we do not have a peripheral pulse, provided that they have a limb, there's no tourniquet on place, make sure that you're moving towards your central pulses. And so that can be your carotid, that can be your femoral pulse. All right, moving on to D.
Disability.
Disability. This patient is alert, they are conversant, and we will also calculate a GCS. So they were speaking with full words. They are able to follow commands and move extremities, and their eyes were awake, did not require additional stimulus. So GCS of 15. E. I'm sorry. Oh, I think we have somebody with a hot mic. Go ahead and check if you need to mute. E. May I have an E, please? Could some
Exposure.
come off of you? Exposure, great. So part of our exposure is ensuring that we're getting that assessment of the patient. And then with us, we're at that point and starting to look at rolling our patient. And so I'm going to move forward our slides. But as I move past this, the rest of our vital signs, they had a SAT of 100%, though we're pretty quick on putting them on oxygen in our shop. And so, so I can't tell you what they were off, completely off oxygen. And their pulse was 126. So important there. I'll bring your attention back to that in a little bit as well. All right. So as I filled in the blanks there, outstanding job. Thank you very much for helping me work through our primary assessment. One of the things is that we also looked at, they were, okay, so 1+, sorry, my recollection gave you a 2+, but reassuring in peripheral pulses with their blood pressure, diminished breath sounds on the left. But the additional component that's important for us to think about is also just that visual assessment of the trachea and if it is deviated or not. And I'll move forward into our next slide and draw your attention to why that's important. But with our exposure, when we rolled the patient, and I'm sorry I don't have a picture to share with you, but I bring your attention to the blood spurting and air bubbling from a penetrating wound of the left lateral posterior thorax. And as we move into our adjunct with the chest x-ray, you can see where that somewhat correlates. You see a couple foreign bodies in this. You will see a ballistic in the left upper lung fields, overlying those lung fields, but you also see a paper clip. And so the our pattern, and this is something that's extremely helpful when we look at looking at trajectory of penetrating trauma, particularly if there's ballistics or if you look at shrapnel or other foreign debris, foreign bodies that have penetrated and traveled, is that we place a open paper clip, open like you open a book when we roll our patient. The open side gets placed on the back. And so what you see in the bottom and lower lung fields overlying is that open paper clip, and that correlates to where there was that external wound on rolling the patient. Rolling the patient early helps to identify all wounds, and it helps us in also looking at if the degree of penetration risk for crossing midline. So we have all of our vascular, a lot of our important vascular structures that are midline. When we have one wound on the let's say on the left side and then ballistics on the right side or vice versa, or if our holes in our ballistics are not matching up, we need to really hunt. We need to be concerned on what was injured, what vascular structures were injured on that trajectory of the foreign body, the ballistic, or we need to look at if things aren't adding up, is there ballistic that's somewhere else? So do we actually have something that's below the diaphragm? Starting to gather more data and information with that. So also in this chest x-ray is that you have some haziness in the left lung fields. And I don't know if you can see my cursor, so I'll just kind of bring that along over here. And that correlates with hemothorax. You also see that there is some depressed diaphragm here. And so when this was rapidly identified as a hemothorax, and that means a chest tube. And so we position ourselves with chest tubes set up on either side. That was a lesson that I shared with our Guantanamo Bay colleagues and just equipment familiarization and knowing what we have on hand so we're not hunting through. And we also put some additional equipment at the head of the bed. This is helpful for us when we start to think about setting up deployed because it is important that we all know where our gear is so that we're not wasting minutes on finding gear. When we're deployed, this may look different. I have shared with you a picture of a pre-packed chest tube insertion kit on the left side, and this kit does include suture. However, when we're looking at securing it, it may be that we're looking at a occlusive dressing as you see here on the left side of your slide. And so with this, it is also helpful to know that our deployed, which is pretty standard across all branches, are chest tube insertion kits because it's looked at vacuum sealing that into a small footprint. That oftentimes creates a curve in the chest tube. When you're placing that chest tube, it's helpful to keep that in mind as you're looking at positioning and looking to direct that chest tube superiorly and posteriorly. And so helping that curve work in your favor is important, but also recognizing that that might be challenging. With this, you see a flutter valve. The benefit of a flutter valve is that if there is pneumothorax, you're not having that clunky atrium or pleurovac that you need to fill with the saline, and this may be enough on to be able to initially secure that and keep moving forward with your patient. Because in our primary assessment, we should be stopping at B. In this patient, when we identify that they have abnormality, asymmetry in their breath sounds, and a concern there. And that may be a needle decompression, that may more likely be a finger thoracostomy and progressing to a chest tube insertion there. All right. So this patient, because he was a hemothorax, we would not want to use a flutter valve. We should see blood filling our chest tube, and I'll give you a volume on that in a moment. But when it's filling that, then we really need to be adding that into a pleurovac to be able to collect. Helps us in qualifying and appropriately allowing that lung to reinflate. So post-insertion, you see this chest X-ray. You see some improved lung fields there. You also can see that, and I'll give you a comparison when we start to close out post-operative, but you can see the heart is now kind of shifting a little bit more into normal over into the left, overlying the left lung fields there. And a reminder too, ATLS has been updated. This is not a recent, it hasn't been in the last year, but it is important for all of us who have done ATLS several times, maybe some of our staff in the audience. We're looking at reducing our chest tube size. So inserting that, not instead of doing our 32, 34 French, moving ourselves down on that. We may be looking at a 28 or less if it's a pneumothorax. And we're pretty confident pneumothorax. It may also then be looking at what would be equivalent for pigtail. And that helps us in the pain associated with it, and it can be equally effective. Though for a hemothorax, we do want to look at maybe a 28 that was placed here. We also have moved this from the anterior axillary line to more of our a little bit anterior to, excuse me, move from our midclavicular line just anterior to the axillary line. And that's partly because of habitus, as there's a lot of overlying either soft tissue or muscle. It increases the ability to appropriately place a needle decompression and to have that penetrate the pleural cavity. All right, continuing through our adjuncts, we have a FAST here, and you will clearly see that this was obtained. There was some concern here on potentially positive with a little bit of blood there, and so this patient, I moved forward my slides a little faster than I wanted. That's all right. This patient quickly then started getting TXA and whole blood. So ATLS supports us in early blood when appropriate for penetrating trauma, our patients with cardiovascular collapse or with hemorrhagic shock, and also acknowledging the hemostatic adjuncts and TXA. This is not new for us as military providers. We know as military physicians that TXA helps in that clot stabilization. It can reduce overall the volume that we end up needing to transfuse our patient and helps us in stabilizing them. We have some criteria at our institution that looks at whole blood, and I benefit from having that readily accessible in the trauma bay, though it is still a discrete resource. And so we look at algorithmically who would have the greatest yield, therapeutic benefit when we're transfusing that. But preferentially whole blood, and that gives us our components not just for oxygen circulation volume, but also with clotting capability there. So this patient had 1200 out in the chest tube, and so they went on to the OR. You'll see here they moved pretty quickly to the OR in their operative course. They had a total of 2 units whole blood. Um, we have a VBG that helps us in correlating. One, it gives us kind of that gestalt on H&H, but that lactate of 6.6 has gone into ATLS algorithm and looking at quantification of shock index or hemorrhagic shock. And we also then look at this patient was acidotic, which is not surprising as they come in. They had dropped their blood pressure by this point, so it did correlate with them needing to go to the OR. And you can expect that with the volume of blood that I have informed you of. They got an A-line to help in guiding their resuscitation. Ultimately, they also had a pericardial window, though it was not determined to have a pericardial effusion. And you'll see here that they also had a esophageal echo, and that helps in looking at overall cardiac function when there's any question or concern on if there had been cardiac injury penetration wound that would have affected that. That's not something that we're going to have the luxury of downrange, but serial echo could help us if we're looking at if we need to be considering was there potentially a nick of the pericardium? Are we potentially developing bleeding? And especially if our patient is decompensating after we place that chest tube. And so I share with you their operative course, realizing that that may be a luxury in some of the places that they are, but because this was all clinically indicated for this patient, when all we saw on their primary assessment was that posterior wound and the single ballistic in the left chest. They had a rib fracture that kind of correlated with their area of trauma, and no other injuries were found. This is the rest of the labs for our patient. As we look at, we are benefited from fibrinogen coags in helping to guide some of the resuscitation. We use TEG for those that are on anticoagulation, but it is not standard for us with the initial trauma labs for all patients. And I give you that reassurance because it's not a luxury that we have in most of our deployed settings. So post up, you'll see this definitely looks like a heart looks more plump. We can see that it is definitely improved on filling. We see that as they have also been resuscitated with 2 units of blood. They have good response to their chest tube on the left. And I will just remind you what that trauma bay x-ray looked like. And when you look at those back and forth, then I'll bring you here. And then trauma bay, we can see that we have a underfilled heart, and we also see that that is shifted to the right. That correlates with some concern also for some pneumothorax. So they were not demonstrating tension physiology. There was no trachea deviation on physical assessment. All right. So clinical pearls out of this case. Early exposure and enrolling the patient is really important as we look at identifying all penetrating wounds and then identifying and trying to establish a map of what organ structures were injured. That helps us in looking at where they need interventions as well as where they could potentially be hemorrhaging. Resuscitation with early blood is important, and I'll move into some discussion as to some guidelines that can help us on that. I'm also going to move into some discussion on intubation. And while this patient did not have intubation in the trauma bay, you could see that this may potentially have been the part of the story for a different patient with similar injury. So I'm going to discuss that next. And finally, we'll close out with some coordination of care. So moving forward, thus far, we've been able to review our primary survey. This patient, and for our penetrating traumas, we do not apply a C-collar unless there was clearly a concern that there was injury. Maybe they were not just shot, but also rolled down an embankment, fell out of a window, history that would correlate. One of the reasons why I include that with this slide is because it is important that you think through C-collar, absolutely important to reduce mobility of the neck if there is any concern with any injury, and that includes blast that it could have caused a cervical injury. However, it can also mask our ability to identify if there is an expanding hematoma or bleeding in that. So it's very important that we also then safely stabilize the C-spine and remove the back of the collar, take a look under the front of the collar, ensure that you have not covered up a wound that we need to address. We use our EFAST in assessing our circulation and then guiding interventions. This is a benefit that all of us have in our hip pocket when we look at, especially if there is concern for pneumothorax, and we are very facile. We really benefit from having embraced that as a specialty. As the dust settles, ample history helps us in reviewing allergies, past medical history, uh, if they have medications, their last meal, the events around the injury. And gathering that can really help us as we get a better understanding and take a step back. There's other things that we need to address. And then a full physical assessment at that point. Is there an extremity wound that needs to be addressed? Is there a dislocation? Is there a fracture that we need to manage? All right, so I alluded to early roll, and in this patient, I described to you what their posterior torso looked like with that bubbling, bleeding wound. This matches our goals for March. And as military, we look at identifying life-threatening massive hemorrhage and control. This may be a tourniquet. This may be a pelvic binder if there was a blast and pelvic injury or a rollover injury, especially with some of our blunt mechanisms. Extremely important. It is also important that we look at if there could potentially be a large vascular injury, and I've seen that in subclavian vessels. And so putting that in context as to where we may see or may have radiologic evidence of injury from penetrating trauma is important. That also it can be managed with packing of a wound or direct pressure. Not everything needs a tourniquet, not everything needs a pelvic binder. We saw a small volume of our deployed injuries having a need for airway intervention. This may be intubation, this may be crike, but it is important that we recognize that early. And that's our next assessment. And this is supported by Eastridge, which if you are new into medicine, new into emergency medicine, this is some of our landmark articles that have framed military medicine and care downrange. And continuing for our respiratory, circulatory, and then avoiding that lethal diamond with hypothermia. And that's especially important when we start to think about functioning deployed in some of our potential future settings. ATLS has given us some additional vital signs to be able to help in guiding resuscitation. This starts to look at pulse pressures and how that can help us in understanding if they're moving into class 2 or class 3 shock. As I said, BBG helps us in lactate. It also helps us in looking at base deficit. And that is something that we have with our iStats downrange. It requires calibration as well as the appropriate cartridges. But base deficit also can correlate. Now, a little caveat for us that are functioning deployed, because we may also be looking at some dehydrated patients that may be adding a little bit to their base deficit. And then we look at a need for blood product. And so all this together with our clinical picture helps us in looking at if we need to transfuse. So let's get going into transfusion. So with resuscitation, we have talked about options which may be low titer O, whole blood. We benefit from that whole blood if we've activated a walking blood bank when we've deployed. That's pre-screened donors that are called and we start collecting. There is some degree of risk with disease transmission. And if you think about everything that's going on when we do need a walking blood bank. It's also hyper important that we are using what's Eldon cards, that's rechecking blood type and not ensuring that we have an accurate blood type, as we're looking at type specific blood collection as well. Particularly our Marine Corps colleagues, they have shifted more towards considering potential Valkyrie, which is to collect blood from a live donor and look at point of injury transfusions off of that, with those that are pre-screened similarly to our walking blood bank, but then managed by a corpsman, somebody without direct physician oversight, in doing that. And so expanding what our volume of blood and capabilities, and really pushing that forward through an option of Valkyrie. We need to recognize if a patient requires either emergency release or massive transfusion protocols when we are working within our established hospitals. This is important in ensuring that we have subsequent units ready and pushed to either the trauma bay, to the OR, to be able to get that blood in quickly. And so know your hospital system and what your emergency release and massive transfusion protocol criteria is. TXA is something that we stock, something that is important in getting with communication for interventions downrange, because our corpsmen are packing this and getting this for our patients early and quickly. I share with you a deployed article related to looking at TEG, and one of the reasons why I share this is because this gave me some confidence. When I'm working in an established trauma center and I'm managing patients, and certainly those on anticoagulation, TEG is extremely helpful, but that's an extreme luxury for us deployed. And this article shared the outcome when they looked at those that had deployed transfusions that were guided by TUG versus clinical, and really matching that 1 to 1 to 1 when we look at platelets to FFP and PAC cells. And so as long as we're sticking to our 1 to 1 to 1, when we don't have the luxury of low titer O, then we can have similar outcomes to when we are looking at TEG guided transfusions. That's with, of course, making sure that we're warming our patients, avoiding ongoing loss. When we are working within the trauma bay, if our patient is getting CPR, we use packed red blood cells. If we identify a patient that is going to be going to the OR, we know that they need multiple units, subsequent units, or we use what is an ABC score, and I'll introduce that to you in the next slide. We use low titer O. And so this is helpful because it helps us to manage what is still a limited asset when we are here at home. Now, our children and our pregnant patients are off to the side because of the regulations on low titer O whole blood. So what was the ABC score? So it's assessment of blood consumption. It is heavily skewed because you get a point for penetrating injuries. And as I explain that to you, you can understand why it's one of the scores that we use in our pen system. Your subsequent criteria is a positive fast if the heart rate is 120 or higher, or if the blood pressure is 90 or less. There's real advantage in us in having the common framework in how we're going to score. It's an established scoring system, but on all of us knowing within the trauma bay, because our nurses can be recognizing, hey, this heart rate is fast. Hey, we had a hard time with that blood pressure, and they're penetrating. Hey, their ABC is 3. Do you want to start blood? And when you're a team lead in managing a patient or managing multiple patients, having a framework such as this scoring helps in that cognitive offload. Yes, I'm concerned on this patient, and yes, we want to be doing that early. And together, we want to be prioritizing the transfusion of blood because we know that's going to make a difference for this patient. Now, our military CPGs, they lean towards shock index. And so simply that's heart rate over our systolic blood pressure. And if the heart rate is higher, so your score is 1 or greater, then your shock index would support looking at blood transfusion. It's not as specific in the factors because it doesn't take into consideration your fast, but it is more comprehensive since it isn't as skewed by your penetrating injuries. Now, intubation. This patient did not need to be intubated, but I do bring some attention to some of the predictors for peri-intubation arrest. When we are moving quickly, we can identify that this patient is in hemorrhagic shock. Their GCS is 8 or less. I am concerned on their ability to protect their airway. I am concerned we need to intubate this patient. Preparing to do that while we're simultaneously controlling hemorrhage, mobilizing if we are going to have other procedural interventions is important. But sometimes you want to take a pause. Sometimes you want that patient to be on oxygen. You want to consider supporting with bagged respirations, but you need to get enough time for that hemorrhage to be controlled with a tourniquet, that you started blood and you have one or even that second unit that's in, so that you have a pressure. Because we know that if they are hypotensive to begin with, if they have that high shock index, they have a higher chance of peri-intubation arrest. And this article that I share with you out of Anesthesia Journal looked at some of the risks in emergent intubations. That also went into BMI, age, things that may be difficult in an intubation, which is also your multiple intubation attempts, as well as hypoxia. That may be pre-state, that might be because you've had a difficult intubation and the SATs are starting to drop. But all of that together has high correlation with patients that have peri-intubation arrest. And if we take that pause and we try to ensure that we have good access and we have blood infusing, and maybe we've supported them through some bagged respirations, then we have done a service to that patient. Because rather than rushing into an intubation that we now have a crashing patient that we're looking at if we need to crack their chest and scurry, we may have been able to support them with enough blood products. Now, this study also took into consideration peri-intubation up to 60 minutes. It also had some medical patients in there as well. So, but it's the best article that I could find that really correlates what has been a practice and what has been something that I have taken away from my time at Penn and I share to you because it has made a huge difference in how I manage these patients. All right, communication. So coming down towards the end here. Communication is extremely important because this helps us as a team stay on the same page. When we're moving rapidly through our primary, our secondary assessment, and we're pausing and having interventions, everybody's all hands on deck. We're practicing closed loop communication as we're starting blood, as we're administering TXA, as we're getting antibiotics on board, but it can be hard to really capture everything that's going on. And our team does a timeout. This was a Penn way that we've adopted and that we take as a deploying team as well, because this gives an opportunity for all of us to ensure that are on the same page. What was the mechanism of the patient? What was their GCS? What was their FAST? What interventions have been completed in the bay? And what's our next action plan? So that may be if they're going to the OR when we're deployed and don't have CT imaging. That may be that we're going to CT for imaging and back to the bay when we are in a comfortable setting that has it, but maybe we're in a small MTF that doesn't have a operating room and trauma surgeon, and we're really trying to think of, do I need to get the general surgeon to intervene, or is this something that can be shipped out? And I'm going to add a little comment in there. If we're functioning in places that don't have a trauma team, that we're not able to continue extensive care, early notification for evacuation of that patient and avoid delay by CT. if at all possible. So get that patient where they need to go when you identify that. When we're deployed, this can be a TCCC card. Our JTS, which is Joint Trauma System, has several different methods. Our TCCC card, TCC card is from that battlefield. If we're having a lot of patients, then this may be the best that we get. But it gets on their original injuries, if they needed to have intubation, if there was a chest tube placed, blood products, room for antibiotics, at least getting that updated as they progress through care will help in ensuring some documentation is moved through. That we also have DD forms that are more comprehensive and most certainly are important when we are able to do that, but at a minimum get some documentation so we've got the basics and absolutely tourniquet time. All right, so coordination of care, we discussed the importance of identifying our patient properly. That may be with standard identification in a hospital system, that may be with military identifiers. Our basic information includes mechanism, all injuries that were identified, and then ensuring that we've updated what their treatment plan is. And that guides the next actions and ensures that we have smooth turnover between all care teams. So as I close out, this was a discussion on trauma care. This discussion looked at general framework, reinforcing ATLS principles, as well as some of our military perspective in managing and prioritizing hemorrhage control. We discussed looking at interventions which included blood products with a span of what was available in either in a controlled setting or deployed and resource limited. We talked about patients that may require intubation and how best to manage that, and if it would be appropriate to pause or delay while continuing to reassess. Together, we work with small teams. Our communication as we're working simultaneously is essential so that we're able to hand off that patient with as much documentation and so that the person who's primarily leading that patient has been able to review and ensure that everything has been kind of checkmarked and everybody is on the same page and holding each other accountable because it's a team sport. We work together and take care of our patients together. It's important that we share information together. And with that, I close out with references. And this was really something that I enjoyed sharing with you. It's something that I have definitely increased in my confidence at the Penn system, but it's something that I share with everyone when I do training in other locations as well, because we as a whole have these refreshers framework that can give us confidence when we're taking care of however many trauma patients wherever we are. And I am just at time. We may have time for one quick or two quick questions. Well, I'll turn it back over to Michelle as well as Dr. Osborne, because this is a real joy in just sharing this experience as well as the framework with everyone. Over to you for any closing comments.
It looks like Dr. Stewart has his hand raised. Did you have a question?
Yeah, I was curious. These military-civilian partnerships certainly seem like a unique opportunity. I'm curious, what do you feel has been kind of the biggest benefit to you of participating in one of these?
I think the biggest benefit is working as a team. And that's because I work alongside those that I'm going to deploy with. And so we've taken care of some challenging patients. And together we really gotten to know one another, and that will help us work together. When I've deployed without having had live patient encounters prior to that as a team, it's a bit rocky as we get that started. Thank you for the question. I think Lindsay may have her hand up as well.
Thank you, ma'am. First things first, thank you for shouting out the Valkyrie program. It's near and dear to my heart since when I deployed in 22, we were the first East Coast MU to take that program forward. Our West Coast colleagues had done it a couple of times prior, but we were the first ones to take it across the Atlantic. So definitely something that I hold dear. My question for you is this, coming at this problem from the anesthesiology perspective, as a soon to be graduating anesthesiologist with still a pretty decent foot in the EM world, what support would you and your colleagues appreciate from our side of the ether screen, in terms of taking anesthesia care forward, in terms of taking capabilities forward, in terms of how we can best support your services?
Thank you. I really appreciate you, supporting in your experience out of Valkyrie, because that has had some ebbs and flows and starts. But really, that's one of the things that helps us when we look at where we may be in the future, and how we get about problem solving. So when I look at that collaboration with anesthesia, I think that our anesthesiologists, as well as our CRNAs, have a sound skill set. And we in emergency medicine, we have a sound skill set, and we overlap in some of those as well. And so having that collaboration back and forth, how we manage a patient, how we function as a team. This is a patient that's difficult to get access on. We are pausing on whether or not we need to intubate. Can I flex over in that? That's something that our anesthesiologist that I work with here in Penn, we've had those conversations and really kind of shifted him and to a little bit more of that jack of all trade, which is different from his functionality in the OR, but is something that really helps us as a team, because majority of our patients don't need to be going into the OR up front. And in fact, if we're managing multiple casualties together, we may be needing as a team to look at how we stabilize to the best of our ability before we lose what can be a third of our team into the OR. And so having that shared collaboration, I think, is invaluable, because it really extends us so that we're doing a lot of things simultaneously, taking care of patients simultaneously, and his willingness to be able to kind of flex from the head of the bed.
Thank you for that. Greatly appreciated. And thank you for everything you do.